Hey guys, hey everybody, welcome back to the another episode of the Vitality Code podcast. I'm here with my co-host and as always, well-bearded brother, Dr. Jeffrey Farrah. I'm Dr. Jason Farrah. Jeff, how's it going?
It's going well, my man. It's going well. Good morning to you.
How are things in Tally Town?
Tally's good. Yeah, a little early for me this morning, but we're here.
Bright and early.
I got 3 kids all on different schedules, which means I get the brunt of all their schedules.
At least you are not. Well, I don't know if you've ever been, but you're not the current victim of a Facebook ad hack.
Yeah, I heard about this.
Dude, I woke up yesterday morning to all kinds of chaos from the bank, from the credit cards, wow,
Who caught it? The bank?
Well, in a fashion, in a way of saying sort of, but not fully. It was the ad agency. I don't know if I should say their name out, but whatever. The ad agency that did and notified us. And then
notified you. Well, that was nice of them.
Yeah. Well, they got hacked, and thereby we got hacked secondarily.
Gotcha. I did get hacked this weekend, but they only spent $200 at online gambling. So, and the bank got it.
Within the last 48 hours, you got hacked.
That's probably Monday or Tuesday.
Oh, so wow! Hacking is at an all-time high.
I think it's just common, yeah.
It's the world we live in, right?
Synovus, man, my bank's on it. This is probably the 4th time they catch. It's never been big amounts, but they always catch it.
The worst part. Well, it's terrible. This was a lot of money, a lot, like thousands and thousands of dollars. But so that was lovely. But then there's that. Then there's the aftermath, right?
It's the aftermath that's worse.
So we went to the grocery store. We have been on the phone I was exhausting, and we're till from 6 a.m. till 2 p.m. at night. Look at this. JP Morgan says attempts by hackers are on the rise, and 15 billion. Probably my gosh. Yeah. It's also, it's such a big deal that it has been for some years, for the last few years, at least to my knowledge, an investing trend too. But anyways, so we were, I don't know. We're on the, I don't know, 6 a.m. till 2 p.m, and then forgot to get back with the bank, and they kind of said they were going to do one thing, and we went to the grocery store to get some groceries.
I had no money.
Boop, my card didn't work. Oh yeah, she said that. Let's try your card. Boop, it didn't work. Oh, thankfully we had a little. We always keep cash, and so cash is king, right? But it was like, wow, this is inconvenient. Now we're heading to a weekend. Banks are closed, so we won't be using these cards all weekend. Try to use my Cash App card. Everything's connected to, it's just everything. It's just a pain in the butt.
I try to use my Cash App card for most around. I only keep a small amount on that, and then I use that for all my day-to-day purchases.
Yeah, that's what I do.
I was getting hacked from a gas station a couple years back. I think that was we narrowed it down to the most likely suspect, but so from now on, I do Cash App for like all my little purchases around town.
Gosh. So that's the public service announcement, the PSA. Who you got in the Super Bowl, man?
To be honest with you, I don't care. Pro football is dead to me.
You're dead to me, pro football.
I like to watch the old Netflix series of like Barry Sanders. That's my pro football consumption.
Dude, I love glory days. School, right? Yeah.
Did you watch that series? I think it was Netflix, or maybe it was Amazon
Prime.
No,
I would love to watch the one on Barry Sanders. That's
good.
Interesting thing. I want to know more about why he stopped kind of in his prime. His mic dropping.
You won't get any answers.
Well, then I'm not going to watch.
It's just interesting.
Amazing athlete.
There was a real strong undercurrent of the relationship between him and his dad. Watching that, and that heavily influenced his career, the way he played football, the way he exited, the way he just lived life.
Wait, I thought I wouldn't get any information on the way he exited.
Yeah, there's no crescendo of like, answer, You have to sort of infer your own. And
so for the Super Bowl, and Nick and Jeff, I am going to pick the Chiefs just based on talent, momentum. I love McCaffrey over on the 49ers. That dude is a beast. But I will say I'm looking forward most to Super Bowl being over, and and I don't know. I don't want to think I'm jealous. Maybe I am, but I am so sick of Travis Kelce and T Swift. Oh my god! And I'm sorry. I don't mean that personally. I doubt there's ever a chance, 0 chance they'll ever be listening to this podcast. I don't begrudge them their fame and wealth at all. But it's like, oh my gosh, bleh, I'm just so sick of. And then
Being
you know what?
force-fed.
Yes. And then, like, dude, I couldn't believe it. You know, I seen on social media, even around town, people we know getting into the T Swift's boyfriend and T Swift and Swifty mania as it relates to the Kansas City Chiefs and all this
Tread
stuff.
lightly, boy. Come over to my house.
Well, okay, that's where I'm going with this.
Well,
hold on. Let me don't steal my thunder. I got to. So I walked in the kitchen yesterday and we're opening up mail and I'm like, what'd you get? What was this? It was a custom made shirt, and I was like, oh, it was like an et tu brute moment. I was like, you too, Morgan. I was like, oh my gosh, and I didn't, because she didn't really talk about it, and she had the shirt, the custom made shirt, like something about I didn't even look, something about my T Swift and the boyfriend, and there's a shirt celebrating their relationship. And I'm like, I was like, oh my gosh, now it's officially, I can't get away from it. Tell me
I'm so
your story.
disconnected from pro football. I didn't know who Travis Kelce was until my middle daughter told me. I was like,
this is an ex-collegiate football player too, folks. By the way,
I am so out of the media pop culture. I was like, hold on, isn't he a Super Bowl champion? She's like, no, he's Taylor Swift's boyfriend. And I was like, what's his name?
Well, he is an ex-champion, but yeah.
Yeah, I had to kind of dig deep into my peripheral knowledge there, but
he's got a couple. Nick, he's got a couple rings, right?
I just know him as a Pfizer rep. That's all I know him as.
With the double Band-Aid guy.
The double Band-Aid.
Not just one. You got to get them both, baby.
Give me my 10 boosters.
Hey, do you think he got an extra bonus for the extra Band-Aid? Like, all right, if I'm wearing an extra Band-Aid, I
bet he made more off of that Pfizer campaign than he did a year of football.
He might have. That's very possible.
Pfizer don't play around, man. You're talking billions and billions of dollars. They're just probably they're probably dolling out 10 million like nothing.
Like it's nothing. Deep pockets, baby.
Yeah.
All right. Well, we each had a little bit of time off. We kind of, I don't know, man. We saw other people. But I couldn't quit you, Jeff. I just couldn't quit you.
Came back.
We're back, baby. So I think you had some, we constantly barrage each other on IG. I never have to worry about my wife being worried about what's in my DMs. It's always
just me.
It's just Jeff. Bing, bing, bing.
It's sad though. Talking about the media and pop culture. All my DMs, I'd only use social media for. I follow some medical people and I follow comedians. That's all I want.
I was gonna say, now hold on. When you just said, I'm not into pop culture,
those are my two categories.
But dude, you're an IG junkie.
I want comedians and I want medical. That's it. I have nobody else.
You do send me some funny stuff. I will say that.
I want the Netflix. I want the comedians. I got the individual comedians. I don't follow anybody else. I don't follow Rogan. I don't follow any of those traditional outlets. I just want comedy and medical.
And so that's a good. Yeah, it's good. It's good. I like it. And so that's a good segue. I think we were recently talking about. We love to look at these other sites and look at this knucklehead, or look at what do you think about this? Or sometimes it's a joke, sometimes it's a real question. We had some interesting, thought-provoking questions come up in your recent perusal of some of the hormone IG pages, or people that are in the same space as us and working and bringing up some issues. It was interesting to see people's responses. Physicians' responses, right? I think
I would just, sometimes I live in, or we all probably do, but I feel like sometimes I don't know how much
chamber.
How much of my world is reality and how much of my world is being shaped by the influences that start feeding me. Once you look at one hormone doctor's webpage, then it seems as if female BHRT is exploding at the moment. And I don't know if that's because they are pushing all that content towards me, which is another reason I try not to consume too much of it, because I feel like it shapes the world. It may make the world seem as different, not the same as it really is. But and so I've started following a couple, I think, prominent BHRT people on Instagram that provide actual good content. And so I thought it was interesting to go read some of their questions and comments. They seem to have more engaged users. It's not the typical YouTube X where it's trolls and people yelling at people. And I don't know if that's a female versus male thing or whatever, but these pages are dominated by female subscribers. And so they, in my opinion, they were asking what seemed to be legitimate questions, and the comments and responses seemed to be genuine asks for knowledge. And so I thought it'd be interesting to go through some of those and find some of the more common themes that were repeated by their users. It was two doctors. One was Dr. Louise Newsom. She's from the UK, and hers is the menopause doctor. And then Dr. Mary Claire, who is US based. And I think between the two of them, they had, I don't know, they had maybe a million users or subscribers.
Were they talking to each other, or what was
No,
this?
no. These are just two separate doctors,
okay.
Both OBGYNs, one in the UK. Gives a lot of information tilted from the UK. So there's a lot of the, I guess it's the NHS over there, their national health system, and some of the issues dealing with that. And then Dr. Mary Claire here in the States, but both of them are BHRT providers. And then the women in their comment section, it's very interesting to see their questions. And so I wrote down a few of the most common themes over and over and over that seem to be getting asked by the users. So I was going to ask you those questions and see if we could sort of elucidate the answers that are maybe by this 2-person Instagram poll, the more prominent questions opposed by females. So yeah, the first one I saw, and not trying to give a shout out to either of these female doctors, but so I don't know which specific page, but this was common threads across both of them. So the first one I saw was, where did my doctor get the information that I was only allowed to do HRT or hormone replacement therapy for 5 years? Is this true or not? ?
Yeah. So
where did that come from?
Well, as best I know, so there was that famous World Initiative study that's been highly criticized for good reason, with methodologic flaws, and then later subgroup analysis and deeper nested analysis and going back through.
Or could it be that was poorly interpreted and it was made to be something it was never intended to be?
Well, that's true. And a lot of literature is like that. Like, there's lies, there's damn lies, and then there's statistics.
Peter Attia
a lot of people don't know what they're talking about.
Peter Attia had a good podcast with one of the lead authors of that. And it was like, oh, you guys never intended it to be what it is, and it was just sort of taken over by the proverbial media that jumped on it and made it seem something that it wasn't, and it got really stuck in the literature. But nonetheless, so
I mean that probably wasn't really intended to be that, but you nonetheless, if you have conclusions, people are going to look at these results and conclusions, and then they may go on to make decisions that, in other words, we want to look at the role of different hormones, and we want to look at the role of hormone replacement therapy in women's health, for instance. But no matter what, you're going to come to a set of conclusions and results, and then people are going to interpret those results and perhaps take actionable or make actionable recommendations based on those. And it may not have been their intention to vilify anything. It may not have been a bias. It may not have been even their intention to look at that one thing in that one setting. But I mean, you have to, that's I'm going to drop a bomb somewhere. I know it's going to explode and have collateral damage. I mean, you got to know. But it just gets to the point of where you have to be responsibly interpreting the literature. You have to be responsibly processing literature. You, as a consumer, now that in this digital age where everything is more available, widely available, unfortunately, you either have to, I mean, you just need to know what you don't know as best you can. Sometimes it's hard to know what you don't know. The bias or the base case is that you don't know what you don't know. But learning to evaluate statistics and things is, at least in a rudimentary way, is useful if you're going to be referring to those and making decisions based on those. But anyways, that study and the Million Woman study all of a sudden HRT in, as treatment for menopausal symptoms and hormone deficiency of aging or whatever, whatever the scenario is, risk of breast cancer, we're not going to do that. Fast forward, women are suffering, secondary menopausal symptoms of neuromotor decline, cognitive decline, osteoporosis, urogenital deficiencies, urinary tract deficiency, infections, lower urinary tract symptoms, cardiovascular effects. And this has been the big criticism of those conclusions, right? Is that you had this multi-decade group of women that went on to suffer from the removal of that important therapy from their lives. And now people are going back and look. And then, so that, as best I know, that comes from ACOG, the American College of Obstetrics and Gynecology, that now saying, okay, 5 years, that's the official recommendation, 5 years post-menopausal, you can do that. That is based on other literature and other studies. Like, I think there's NCCN guidelines, NIH guidelines, that you can use those even in certain disease states like BRCA and things. And there's an arbitrary number, of like up to age 52 and or short term. So if you're getting your ovaries removed at 45, you can use it for until you're 52. That's 7 years, so that's roughly. But the official reason what I know of the 5 years is that's an official recommendation from ACOG. But to me, again, that same recommendation and the literature it's based on is still under further review, and we don't have high quality, multi-center, randomized, prospective, placebo-controlled, double-blind studies that are that produce practice-changing data that we can rely on. We have massive amounts of cohort studies, massive amount of retrospective studies. All these are things that are lower grade data. But until we have massive quantities of very high grade data that's practice-changing data, and hopefully that is ongoing, that you have to take this with a grain of salt. But that's, as far as I know, that's where that comes from, is the official recommendations from ACOG.
That was a very you should go into politics. That was that was your long.
I'm gonna get my right. Is that the thing? I did not sleep with that woman.
Yeah, no, that was good. Yeah, I think that's where most docs, especially if you're not a specialist in that area or you're a primary care, you how do you synthesize millions and millions of data points, and you have to rely on things like the ACOG, and you're like, well, I'm not a gynecologist, I'm not in obstetrics, I'm a primary care, and the specialists in that area who have had dedicated their life to the research and understanding of it tell me this, so that's why I say this.
So you have to realize why people practice the way they do. Not you personally, but I mean, well, all of us do, but the public. So there is one thing, okay, and you probably noticed this as you went through your training, various levels of training. I know I did. There was, and I didn't realize it until I got challenged. Why are you doing what you're doing? Because I train at Wake Forest, and that's what they said there, and that's what the book says, and that's, I don't know, because that's what I don't know. So there's the bias of that was the Wake Forest way, or that was the Duke way, or that was the whatever way, that was the Palmer way, or okay, so that's one. Then there's whatever the current literature was when you were taught, and if it's book knowledge, not journal articles and peer-reviewed journals, that's 5-10 years old. So
10.
Yeah, okay, yeah. So 10 years old. Then so that's another reason. Then I never will ever forget this. You've heard of Z-Dog MD?
Yeah.
Okay, so he has a podcast, and he has other things besides those music videos, through the years, and he's pretty big now at this point. But I remember him having this discussion about his dad, who was a physician, and telling him how to practice. And he's like, son, when you go into medicine, you need to be risk averse, be totally risk averse, and this is how you're going to become a CEO, be totally risk averse. Just do what's in the protocols. But there is something to that. We all have to be concerned. We all have to buy medical malpractice insurance, right? And so there's the common denominator and the common medical legal umbrella and coverage, which if you operate under, you're safe and you're practicing safe. So one of the key things about general surgery, I don't know about other surgical specialties, but when you go to take your boards, is we're trying to produce safe surgeons. Now, in surgery is a little bit different because you can really mess somebody up because it's an invasive endeavor. Well, you can mess somebody up with medicines too, but I mean, any kind of medicine. But so if you're out there, like you said, and you're not a specialist, you're not at the cutting edge of research, you're in a busy practice, you're 10, 15 years removed from training, you may not even be on the most cutting edge of your knowledge base, which it's always a tough thing to do. I don't look down on anybody for that, because it's constantly an evolution. It's hard to keep up with. The human knowledge base is doubling every few months now at this point. I read some statistic, it's ridiculous. Then you do what you know, and what is safe and what you're comfortable with. And then, so if you are out there in the world practicing, you have medical legal coverage from institutional protocols, from research, or society guidelines. So if you're an OBGYN prescribing these drugs, and the American College of Gynecology and Obstetrics says 5 years is okay, you have a legal base case of an expert panel, a governing body, to protect you and the supposed medical legal risk to you when you prescribe those hormones to a woman who may go on to develop a cancer and sue you, even though that probably is not the cause of it, but because of the studies of 2002 and the Million Women study and different things, somebody may try to sue you, right? So these are the reasons. These are some of the reasons we don't always practice medicine based on what seems like straightforward methods. There's these things like trying to make sure you're medically covered, and you may be just doing what somebody taught you, or outdated literature from textbooks. You know what I'm saying? And
100%. Yeah, medicine doesn't necessarily promote innovation from a practitioner standpoint.
Right.
It's very. I found this to be true very quickly. It is really disconcerting to a physician to be practicing on the fringes of medicine, which is on the backside is good. You don't want to be doing all these negative things, but it also stifles innovation. It also stifles.
It's massively stifles innovation. There's a storied history of that.
Yeah. And I think for me, having been a chiropractor first, like I was thrust into that realm of not being accepted by mainstream right out of the gate. And I had to be comfortable with my knowledge base, and I had to be comfortable with the way I practiced, because I was being told constantly. I remember, my first move to Tallahassee, the way I started my practice was I pulled up the, believe it or not, Yellow Pages at that time. I still remember I had a Yellow Pages. I had a Yellow Pages rep. I had a Yellow Pages rep.
A rep was a rep. Oh man, you old, son. You old.
So, wow. And I just went to every physician I could, and I called them, and I asked to come to their office and bring them lunch and talk to them. And I actually made that food, and oftentimes myself in my own kitchen, believe it or not. I just couldn't afford to cater it. And I remember getting cussed out by physicians, like, what the hell is a chiropractor doing here? You guys are assholes. I can't stand you. Let you in my office. Da, 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 da. And some opened me with, welcomed me with open arms, and some. So, but I say that is I had to be comfortable with what I was doing, and I couldn't crumble from that, or else I wouldn't have made it, and then it wouldn't have. If I had believed what they said, and I wasn't sure of what I was doing, then I would have been like, yeah, why am I doing this? This is stupid. This is fake. This is hurting people. But I was like, no, this is not what's happening. I am comfortable with the research. I am comfortable with my experience. I am comfortable with what I'm doing. And so I got used to practicing a little bit on the fringes of medicine, so to speak. And so, but it is not promoted by medicine at all. You learn algorithms, and even in chiropractic, it was really frustrating to me to practice in this old dogmatic way, because that's the way everybody else practiced. That's the way it had the big research base behind it. But it was obvious to me a lot of those weren't productive and weren't beneficial to the patient. And so I chose to practice outside those bounds very quickly. But it was not something that was, even at school, which I would think should have been the area where it's safe to explore some of that, it was not promoted at all. So that's quite true.
Even in the chiropractic school?
Chiropractic school, yeah. I remember challenging many a professor, and I sort of garnered the perception of being a cantankerous, if you will, student who would just challenge. But there's a lot of dogmatic information, I felt like, and I was like,
there's always dogmatic information.
Yeah. And so, But nonetheless, yeah. So I think there is that.
But you are
stifling inhibition.
cantankerous a little bit.
Right. I mean, they were right, but that's besides the point.
Shut up! You're like, shut up. But no, but you're right. And like for me, I think of the one of the most commonly performed procedures in all of general surgery for any general surgeon. Let's say, for instance, and is a laparoscopic cholecystectomy, taking out a gallbladder with little incision.
Oh, right? Is it really?
Oh yeah.
I got a funny story about that.
Tell me.
So I was a nurse when I was doing my surgical, or I don't remember what rotation I was on, but I was in the surgery.
Were you in the OR?
OR, but I wasn't. I was in that morning. Like everyone was getting prepped. I think I was doing the IVs. That's what I was doing. I was doing the IV starts for
anesthesia,
anesthesia and all that. So the board, they had a whiteboard at the hospital.
The surgery board,
yeah. An older nurse walks in. It was a guy, older. I don't know. He was older than me, so he was older, but had been there for a while. And he's like, Dr. So-and-so is here. Look, we got a bunch of gallbladders. What did he do? Stub his toe? Take his gallbladder out? Oh, he's probably got a bad back. Take his gallbladder out? Oh, what did he get? The sniffles? You're taking his gallbladder out? And I remember being like, what are you talking about? And they're like, this guy takes everybody's gallbladder out.
Yeah. And there might be some of that. I always got to take the moral high ground as an acute care surgeon, or get to as an acute care surgeon, because we get the nasty gallbladders. But there probably is a lot of gallbladders taken out. Who knows if you're always, it's an absolute need and everything, but
well, then, it's not always just some malicious thing by some doctor. It's how he views the world and how he views the systems, and if you're having that's probably related to your gallbladder, right? He's not necessarily practicing out of some malicious intent.
No, that's absolutely true. And what's even more true is the guy that was saying that, it's called the courage of the non-combatant. So easy to criticize, right? When you're not the guy in the stadium, that famous quote, but the courage of the non-combatant. And it was one of the things that was the most absolute, it's unreal, the understanding, the educational disconnect between the surgical techs and nurses and the surgeons on the indications for surgery and why they're doing them. And they perceive that they're just doing, and there there may be some of that from time to time. That's possible, right? I'm not saying that every surgeon's beyond reproach, but what I found, it was so frustrating. And then trying to convince people when you go to post surgery and you're like, oh my gosh, like, it's just gotten extreme after COVID too. I would have people like bleeding from their neck and their mouth, or from a tracheostomy site, from their airway, and obstructing their airway. Trying to and he's like, can't you just wait till morning? The anesthesiologist, I'm like, dude, this guy has got a hemoglobin of 6. He's hypotensive, and his airway is being obstructed by the blood that's into, some guy operated on him. I was covering that night. Someone else had operated on him. I mean, what do I have to do to get somebody on the OR schedule? It's crazy, in the middle of the night. Yeah. But that same thing is, you're just doing the gallbladder just because you can't. And there is, but yeah, there's a poor understanding, and also there's no malicious intent. But we digress. But
and that was true. I remember that in chiropractic when I switched over to nurse practitioner. There's very much this mindset amongst chiropractors that medication is heavily overprescribed, is a poor way to practice by prescribing everybody medication. That everybody's over medicated. Medication kills everybody, and regardless of whatever grains of truth there are to that, I never felt as a chiropractor that I had that podium to stand on, because I didn't understand those patients and I didn't understand the medication. Right. So how could I even talk about it? And that was one of the reasons I went. And I remember talking to some of my chiropractor buddies like, oh, you're going to the other side. You're going to the dark side. I'm like, so if you really want to get people off medication, and you really think it's that terrible, why haven't you taken the time to go learn about the medications and go to pharmacology and learn the pharmacology?
Exactly.
Of the two of us, I'll be the only one poised to actually take the person off the medication. Or I became to understand that as a chiropractor, I had the luxury of treating a subset of patients that were not infirmed enough to even I got, I had a higher educated patient base. I had a better insured patient base. I had a less sick patient base.
Less acutely ill
as a chiropractor than I did when I became a nurse practitioner. And so I was like, oh, it's a very...
Not to mention, they're doing the very thing that that you experience and they probably don't like in reverse. Do you know what I'm saying? Like, why the chiropractor? And they were saying...
100%.
And like, wait a second, hold on, you guys don't even understand soft tissues and manipulation of. I mean,
I had a neurosurgeon one time, and we had a dinner. It was hosted by these neurosurgeons, and he got a little tipsy, and he was like, you chiropractors, every chiropractic patient I see, you guys don't do any good for anybody. And I was like, oh, that's interesting, because I say the same about neurosurgeons. Because we had selection bias, right? If you did terrible with a neurosurgeon, you came to the chiropractor.
Yeah.
And if you did bad with the chiropractor, you went to the neurosurgeon.
Yeah.
But if you did great with a neurosurgeon, you never came to my office because you did good already. And if you did great with a chiropractor, you never went to the neurosurgeon. Exactly. So all we knew of each other was how bad each person was. Selection and I remember bias. Thinking like,
huge.
Yeah. And that moment was quite clear to me, because as chiropractors, we were always like, oh, neurosurgeons, and I was like, maybe we're just seeing the ones who don't do good, and maybe that's a small percentage. I don't even know. Maybe it's a big percentage, but they're only coming to us if they do bad. All the ones that do great never come back because they did great and they don't need us.
It reminds me of the book Factfulness, which is a fantastic book. And looking, you're going to get the most clicks, views, hits, whatever, for negative stuff, right? And you're going to say, or the one crazy event, the police. And I'm not saying there's not issues with police violence. I'm not saying that, but it's just maybe that was probably a bad one to select, being such a polarizing thing. But I mean, when you highlight one incidence, it's complete selection bias. You have to view it against the whole. Like, everybody's destitute in sub-Saharan Africa. Yeah, but actually, if you look at the world population, more people have been lifted out of poverty in the last however many decades than ever. Globally as a society, we're way better off than we were hundreds or thousands or whatever years ago. On and on. So selection bias looms large. But the point of that story was that was chided and derided as, oh, you're gonna do, boy, you're gonna go in there with a camera and take it. Seriously, I mean, like before, we were just getting these big whacks, over here on the right costal margin, opening hernias, all the bad stuff, and you could do. I mean, that guy that invented the procedure, again, innovation against the institutional crush of scientific dogma, right? I mean, wow, kudos to those people that could actually stand up to that and push ahead, and we're better for it. The same thing happened in my career, in my lifetime career and experience with robotic surgery for me. And it was funny, this is bullshit for an acute care surgeon, blah, blah, blah. And then my partner, who was the head of the program, I think you're doing pretty good with that robotic surgery. I think I'll learn. I'm like, you were just saying, and so, it's interesting. But so I think that's why whoever has that question, or whoever had that question, it's from a governing body, and it's a way to hedge. We're going to say for 5 years, and then those who say that are only following their society guidelines, and
right. And that's not a bad thing. It just is a thing. It's not good or bad. It just is. And I don't know that.
Well, I mean, I think you have to good or bad in the context of what. So it may be bad
because I think it depends on the patient is how I view it. If the patient prefers institutional information, safe, slow, I'm not an innovative patient, I don't want to live my life with a practitioner who's practicing on the fringe, I'd rather you wait and be a late adopter. That's their choice. And I think so that's what I mean. It's not good or bad. It just is.
It is. But with everything in life, and I see this all the time in medicine, I talk to residents about this, other practitioners about this, is people, to me, I like to take that sentence and all those sentences to the point where there's a comma instead of a period. It wasn't like your intention, but if you put a period after that, you're categorically right, and I agree with that. But to me, there's actually a comma. I want to be a patient that doesn't want to be on the fringe, wants comma, and I don't mind losing out on the benefits because I fear the risk too much. I don't feel like,
right.
So that's what I mean by bad is that maybe there's the benefits that they're losing and the things they could be experiencing, as long as they're finishing that sentence and they're right. That's just me. I mean, that's how I view it, because I just think people should avail themselves of all the options and the complete picture to then make the decision.
Correct.
So I always like to put a comma there and then continue out. But yeah, that's
Okay.
where that comes
So-
from. You got another one?
So the 5 years from HRT, we're going to say, I agree. That comes from the ACOG, and that's a widely held understanding of hormone replacement for females. So the next one I saw is, so estrogen seemed to be the biggest discussion of the hormones, estrogen, progesterone, testosterone. So this one was, is there a case for women to take estrogen even during perimenopause when they are still making estrogen? And the follow-up to that and the same question was, my doctor told me I couldn't take estrogen because my body was still making it. Therefore, I wasn't allowed to take it.
I don't know about society guidelines. I'd have to.
I don't think there are any official ones.
But that's an interesting one because I have seen this in the clinic recently. I would say that it is, in doing this for a lot of years and really trying. I mean, not trying to toot our collective horns, but this podcast is really just simply an extension of an ongoing discussion that you and I have had for, geez, man, we can literally say decades at this point. We're getting that old, right? Ever since we both got into medicine, let's say, of any type, we constantly have these discussions, like just by the nature, just who, I don't know, or whoever we are, our genetic makeup and our interest, right? So I think that is an extension of that. And I would say it is completely naive to think that you wouldn't do that just because you have estrogen in your body. To me, it's like saying to a man, you don't need testosterone, TRT.
It's a good analogy,
right? Like just you got testosterone, but why do you need it? So you have to say, because then it's like this. why do we care about or even have normal ranges then? Why don't we just have a plus or a minus on the lab sheet? Why do we have numbers? Why don't we, if that's how it is, why don't we just have a plus or minus? Yes, plus you got estrogen in your body, minus you don't. I mean, why even calculate numbers if by that same logic, right? So where I'm going with this is, do you have enough estrogen, considering your volume of distribution, your genetic makeup, your yada yada yada? I mean, a depressed person, you've got some serotonin in your brain, so you don't need antidepressants. Well, apparently I don't have enough serotonin, right? So estrogen, do I have enough estrogen to avoid vaginal dryness, to avoid vulvar vaginal atrophy, painful intercourse, thinning of the vagina, bone health, cognitive decline, lower urinary tract symptoms, life expectancy, Parkinson, so there's a certain effect. That's why we have effective doses, right? That's why we talk about titration, right? Because there's a certain, it's not ones and zeros like a computer. It's not yes or no. It's not like pregnant, not pregnant, So to me, that's a massively flawed argument. It doesn't even have logical basis, let alone scientific basis. To me, that's how I see it. Do you see it similarly? Or
I agree. I'm gonna put a little nuance because I teach some doctors estrogen prescribing, and so typically I tell doctors in certain settings, if they are learning hormone replacement as a new endeavor for them, I tell them don't do estrogen on a cycling woman as a rule of thumb while you're learning, because the treatment, this is my rationale for them, is, and there's been an explosion
even if they have symptoms that are estrogen specific.
So here's the setting. Let me put the setting in there. Is a lot of times there are I'm teaching more and more medical practitioners who are practicing out of a spa, out of a med spa, and so I tell them, hey, the treatment window for estrogen is much smaller than it is for testosterone or progesterone. So you have to get good at prescribing estrogen. It's not as easy as some people say, and it's not as evil as some people say, but it is a little more, in my opinion, more difficult in the prescribing nuance in terms of how to titrate your dose than either testosterone or progesterone. So I say, because of that, a good way to start your practice is don't do estrogen if they're still cycling, because you will probably make a mistake on your dose, and you can lean into it after you get the ball rolling.
And now, if they were cycling, what would that mistake be? The only reason I say that is because the obvious mistake is somebody being amenopausal and then having, uterine dysfunctional uterine bleeding or some kind of breakthrough bleeding or whatever, basically having a period when they didn't before.
Yeah.
What does the mistake, quote unquote, look like when they're cycling? How will you know that you made a mistake?
Well, I find that the ovaries, when they're approaching in this premenopause stage, they don't just take a slow, steady drop, right? It's almost like, hey, I've been having these symptoms of low estrogen, and then the ovaries kick on, and then the estrogen pops up. Like you might not have a cycle for a month, or it might be late for a few ones, or the flow might change, and all of a sudden it regulates. And it's like, well, what the heck just happened, right?
Well, what is also described is that you will lose progesterone prior to losing estrogen, and that is the best. People love to just say carte blanche, estrogen dominance. I'm going to prescribe progesterone. Estrogen dominance. Estrogen dominance is a symptom of perimenopause, which lends itself to irritability, irregular periods, maybe breast tenderness and things like that. I don't know that one for sure, but mostly irregular periods and or kind of psychosocial kind of, or just kind of dysthymia and things like that as the progesterone leaves and you're left with estrogen dominance. And I've seen these people where they have like virtually no progesterone, no matter what stage of the cycle, and massive dose or endogenous levels of estrogen. So I bet you that could be a mistake, so to speak, right? I mean, if you were bumping that up.
And so I just think that I tell patients or clinicians, once you get good at this is not your out of the gate. Stick to the patients who are a little bit easier. And one of the ways to eliminate, because I also practice I was still trained primary care. We're taught to be kind of scared of everything. At least I was, and you're sort of still. So I was taught to be scared of hormones, and so I tell clinicians, this is the way I practiced when I first started, and here's some of the things I've learned. And if you're not good at this, I'd rather you not come out of this training, so to speak, cavalier, thinking you know everything about hormones, thinking you know everything about the nuance of this, and there's no way I could ever hurt anybody with estrogen. And I mean that not medically, but subjectively. Like, no one wants to walk out of a hormone replacement pellet implant and you're feeling bloated and breast or tenderness and you're having a heavy flow and extra cycles and all that because the doctor was like, give everyone estrogen, And so I tell clinicians, and because I'm doing more and more spa trained clinicians, or like I recently trained a clinician and she came out of nursing, went straight to nurse practitioner, went straight from nurse practitioner to work, and never practiced extensively. And then she became the medical director of this chain of spas, or not spas, but chain of like pop-up clinics. And I was like, I'd go cautiously. Like, you don't have a lot of real world experience here. And so one of the ways you can eliminate a lot of mistakes is going light on the estrogen. So while I agree that's not true, you got to understand a little bit more. It's a little more nuanced when someone is in perimenopause to prescribe estrogen. It's much easier when they're menopausal.
Right. And so I think it's the way I would answer that question is it's not that you can't, it's that you may not need. Let's delve deeper into what your symptoms are specifically, and if you would even benefit from, perhaps testosterone would take care of all of your, assuming your testosterone's low, take care of your symptoms, perhaps a trial of it, and then seeing what symptoms are left over, and if those symptoms correlate to raising your estrogen, and then after that going slow. So that's,
and also I think I tell them not to be numbered. Don't just look at numbers and not look at your patient. Oh, your estrogen is 27. You need estrogen, right? Like, look up and ask the patient, are you having estrogen symptoms on both sides of that coin? Like,
I was about to say, also, you have estrogen in your body. You don't need estrogen. So are they having symptoms that estrogen could even help? Yeah, good question.
So yes, there is a case for women in we'll wrap it up, premenopause to take estrogen. Yes, I think
maybe a little
bit
more difficult to execute on for the beginner, or even someone seasoned. But yeah, it's not like you can't have it or something like that.
And these are no order, so let's go to a more technical one here. Do you have any recommendations for a 46-year-old female with a BRCA2 gene mutation?
As it relates to what?
Hormone replacement. I was told that I could not have hormone replacement.
And did they say why they couldn't have it?
Because of the BRCA2 gene.
And the BRCA2 gene and the risk of breast cancer or something, or?
Didn't say. I'm going to infer yes, that was the.
So I think the thing that gets the biggest press is the risk of breast cancer. I've seen various statistics. I saw on the was either the NCN or NIH website, NIH, 13% of women in the general population, which I saw lower numbers elsewhere, but 13% of the women in the general population will develop breast cancer in their lifetime. By contrast, 55 to 72% of breast cancer, or 55 to 73% of BRCA1 and 45 to 69% of BRCA2 by 70 to 80 years old. Obviously, a massively increased risk, right? So it's probably breast cancer. So then I was thinking about this question. In all fairness, that was one that you had sent to me before we aired. I was looking at it, thinking about it, and I was like, well, wait a second. This is, again, you always got to, what I've noticed is you've got to, it's tough. It's tough for patients. It's tough for practitioners for that matter, but to drill down on that more. So the first thing I think I would want to know is, okay, is estrogen itself a risk for breast cancer? Well, recently you have to say, I think if you were back in the year 2004, you'd say, oh yeah, can't do that in postmenopausal women, blah, blah, blah. But it's not as though they were taking out people's ovaries so they would never get breast cancer. So, but nonetheless, okay. And, then those studies got reanalyzed and then, well, maybe it's not that big a deal. And so I would take it even a step further and say, okay, is it a risk of breast cancer, but is it a risk of estrogen receptor positive breast cancer? So if you have estrogen receptor positive, so you can remove the tissue, you can remove the cancer, you can prophylactically remove it, of course. You can remove it, and then you can do neoadjuvant, so chemoradiation before, that's neoadjuvant, or you can have surgery and then chemoradiation after, adjuvant. So there's ways to get rid of the cancer, right? Is to remove the cancer. Then you're looking at preventing recurrence or getting microscopic cancer cells that are either floating in the body or in the direct bed of the surgical field that you may have missed microscopic. How do we do that? Through chemotherapeutic options and radiation. Okay, so the question really is, and then if it's estrogen receptor positive, I'm going to kill that cancer or reduce the risk of its recurrence by withdrawing estrogen from the body. But that was only one of several arms. The other arms were perhaps other chemotherapeutic agents, depending on the type of cancer and morphology and all kinds of histopathologic subtypes and analyses, radiation, and of course, the direct removal. So the question is more, am I going to just take that little sliver of reduction and what does that amount to? And then it has to be, in my mind, it has to be an estrogen sensitive tumor. So it needs to be estrogen receptor positivity. So then you got to ask yourself, in those patients, what is the risk of it affecting estrogen receptor positive tumors? And so if you look, there's actually, and again, there's not, to my knowledge, there's not double-blind, placebo-controlled, randomized, massive, multi-institutional prospective studies, but there are pretty decent studies that actually shows a possible protective effect of estrogen only, for instance, in BRCA1, and oh, by the way, in BRCA. And oh, by the way, a majority of BRCA2 tumors are estrogen receptor positive, 77%, whereas in BRCA1, it's not. So the first question is, I apologize, let me back up. The first question is it BRCA1 or 2? In BRCA1, they don't have a big predominance, at least, of estrogen receptor positive cancers, at least as what I could find in the literature, okay? And I'm not a breast surgeon, and I'm not a hemo doctor, but as a general surgeon and a consumer of current literature, what I could determine, as best to my knowledge, was the majority of BRCA2 tumors are estrogen receptor positive, about 70, upwards of 77%. There was a Nature article in 2019 elucidating this, but not so in BRCA1. So if I'm BRCA1, I wouldn't worry about it. Then you want to say, in those BRCA2s, do I have a chance? And it depends too. What are you going to do? Are you going to get rid of the breast tissue? Is the breast tissue going to there? How are you going to monitor it? What are you doing? But interestingly, there were some Italian studies demonstrating a 8% risk reduction for every year you were on estrogen only hormone replacement therapy after undergoing risk reducing bilateral salpingo oophorectomy as a BRCA carrier. So the reason they do that is so they remove the ovaries and the fallopian tubes because there's a higher risk of ovarian cancer and fallopian tube cancer in BRCA carriers than compared to the general population. 1.2% of women in the general population have a risk in their lifetime of getting ovarian cancer. 39 to 44% of BRCA1 and 11 to 17% for BRCA2 by age 70 to 80. Okay. So that's why they do that. And then you're left with surgical menopause. Interestingly, there's a couple studies that I found that showed risk reduction of developing breast cancer in estrogen only hormone replacement therapy protocols. Of note, if you added progestin to the estrogen, you had an 8% increase in risk. And then there was a subgroup analysis also out of Italy that showed an 18% reduction in breast cancer in estrogen-only therapy, but a 14% but also they called non-statistical increase in breast cancer if you added progestin. So the progesterone is an interesting thing because here you are with these women, and this gets complex because here you are with these women who have had risk-reducing bilateral salpingo oophorectomy but have left the uterus. Why? Because the uterus, just taking out the uterus adds a greater degree of complexity and possible surgical complications. We're down in the pelvis by the bladder. Well, it's all down in the pelvis, but I mean, there's a higher chance of injury of the bladder, the colon, scar tissue, then the risk of, do you take the cervix, do you not take the cervix, sexual risk, all kinds of things. Women might say, I just get rid of the uterus. But if there's a uterus intact, though, there's endometrium. And if there's endometrium, there's risk of uterine cancer. So then you ask yourself, okay, do BRCA mutators, do they have increased risk of endometrial cancer? Because we don't hear that a lot, right? What I could find is that there is a slight increase in risk. For instance, there was a Dutch study that showed I think it was 3.4% compared to 2%. So, in BRCA mutators for uterine cancer, they do have a higher chance of getting a serous type of cancer, which doesn't seem to be I'm not an expert on uterine cancer, but it doesn't seem to be as lethal or as bad. But the risk is pretty small. But I say that because for the average person, you're going to say, oh my gosh, there's that uterus and I'm giving estradiol, got to protect that uterus. And you do. I mean, I get that. In general, it's thought that estrogen dominance without protective progesterone will increase endometrial thickening in perpetuity and to a great degree, and thus potentially increase risk of uterine cancer. In general, that is physiologically true, and there's a physiologic mechanism for that. But if you give that person, and these specific people, you may not want to be giving them progesterone because maybe you're going to be increasing, there's more studies needed, but maybe you're going to be increasing breast cancer. So I'm a 46-year-old. The first thing I'd have to ask is, are you BRCA1 and BRCA2? I would say, are you going to do risk-reducing salpingo oophorectomy so that you would be put into surgical menopause? I'm assuming so if you're asking the question. And then the other question is, what are you going to do about your breasts? If the breast tissue is not there, then I would, my bias after looking at the literature, my opinion, my expert opinion after looking at the literature, and in that scenario where you're taking the breast out, is it's kind of a no-brainer. I mean, I think the secondary menopausal symptoms should be avoided, and you have high risk of Parkinson's, cognitive decline, osteoporosis, massive things, sexual side effects, hot flashes, on and on, just to, and you're not going to really get a benefit. And so estradiol only is how I would do it. Of note, there have been guidelines now reported in Europe, at least, perhaps in the United States, that short-term HRT in those patients are okay. Again, short-term. What I could find is there was an arbitrary cutoff at age 52. I do not know the exact reason why 52, but so what I would say overall is find out which BRCA you are, because again, if you're not a BRCA, if you're BRCA1, to me, there's not even a predominance for estrogen receptor positive breast cancers in those women, as far as I can tell from the literature. So it may obviate the need to carry out that question so far. In BRCA2, as best I can tell in the current literature, and the studies that I was finding were ranging from 2018 to 2023, so pretty current, and it doesn't look to be an increased risk, interestingly. And furthermore, I would also say this: I didn't see in the studies people talking about DIM, and looking at phase 1 and phase 2 metabolism of estrogen in the liver, and the production, or in the case of using DIM, blocking the production of the specific type of estrone, hydroxyestrone, that has been implicated as being a promoter of cancer, and specifically breast cancer. So yes, estradiol only. Yes, use DIM as added protection. And I don't see where you'd be at increased risk of breast cancer, as best I can tell from the current literature. What say you, my well-bearded
I think you did a good job. I think you did a good job elucidating that. I think two things. I've become more. DIM was the one you said there last. I use it a lot in my male patients. I have used it less and less, or considerably less in my females, but I have become more and more attuned to the potential need for using DIM in my female patients because of that diversion away from the estrone production. I think I was using it more for estrogen blocking, and so I kind of viewed it through that lens in my male patients, and so therefore led to less of my recommending it for my female patients, and I've kind of had to reevaluate that and look more of its applicability for my female patients.
I like the idea of it being increasing the free testosterone in both sexes too, especially when I had a recent case of a woman who I was able to get her testosterone up to 10, or it was like 110 or something. And she originally came in, had symptoms of low androgen and low testosterone, was not menopausal, and her endogenous estrogen, or her endogenous testosterone, was 15. We got her up to 110, and she said she didn't feel anything. And I was baffled. I'm like, But it was interesting, on second glance at her labs, her SHBG was 166. And I was like, oh.
That's huge.
And it's huge. And her free was like, the range in the lab was 0.2 to 2 as being normal. Hers was only 0.6. And when she came in, it was like 0.2. So she barely moved the needle. I'm like, oh, no wonder you don't. In that person, DIM could raise the free testosterone and be a useful adjunct. Well, in all people, really. But she would highlight that in stark relief to me, because I think the reason that she wasn't, quote unquote, feeling it is we literally didn't move the needle much on her free testosterone. So
yeah, and the DIM will help with that.
Yeah.
The other thing I wanted to comment was, I think there's some internet personality types that are selling sort of genetic testing and finding out if you have the MTMFR gene and if you have this and that, and they're trying to sell you supplements and things like that. So I get questions about that. I always tell specifically my female patients, yes, there is some practicality to getting genetic testing, but I like to tell them my practical advice, and see what you think about this, is I tell them, let's have some actionable steps in place should you get some information that says you have a propensity towards something. Because just having the information and doing nothing over it is just going to be a black cloud hanging over your head. Now you have a 50% increased risk in ovarian cancer because you're a BRCA2 carrier, or and well, what are you going to do with that information? We need to decide that beforehand, because my opinion is, if you're not going to do anything with the information, then what good is the information? And so be cautious because I've seen some patients who just live in a state of fear. So I tell women, like, let's literally discuss the reality in your life. If you became a BRCA positive and you learned this information, would you do bilateral mastectomy? Would you do surgery to remove the breast tissue? And that's a very complicated decision, and I think it takes the beginnings of it is best done without necessarily knowing that you have to make the decision right then and there, and you have this black cloud hanging over you, which can then feel like a ticking time bomb or something like that.
Yeah, that's right.
And so I tell them, typically what I would recommend is we have an option for surgery, or we have an option for increased monitoring should that information come back before you get the test.
Maybe with higher level modalities, like maybe you're doing breast MRI or
Yes, specifically breast MRI. I had the oncologist tell me, he's like the mammograms are screening tools and not diagnostic tools for breast tissue.
Point, yeah.
MRI, and if you're BRCA2, they wanted BRCA, you wanted every 6-month MRIs.
Mm-hmm.
And I was like, that's a big investment, and you need to know that, and you need to be willing to do it, because then otherwise you have this information. So I think part of that, for me, the practicality side of it is, let's have this discussion, let's learn more, let's dive into the literature, and it may not be as cut and dry, and it may not be something you want to do. That's okay to not know that information as well. So that I agree with your information. That would be the two things that I would add to it.
And what you said was it may not be something you want to do. So that brings up a whole other issue too, and in cancer therapy and treatment too, I think it's time, if people aren't doing it already, to normalize personal decision making in those scenarios, because it's their life. I mean, like, you don't need to live your life according to some guideline if that's what you don't want to do. I mean, practitioners need to be ethical, and you need to avail patients of all the information, because that's your job, and it's also the ethical thing to do, and then they make the decision. Like, I had a woman come in recently with a history of breast cancer and was wanting, in menopausal, and was wanting hormone replacement therapy, and I was incredibly reluctant to do so. We eventually settled on testosterone only, but because there's no increased risk. But I'm going to tell you, it was tough, and hearing her story was tough, because she had gone through all this misery, basically, of all these estrogen-related symptoms, the hot flashes and the vaginal dryness and vulvovaginal atrophy, and not feeling like herself, and didn't feel desirable. I think she had lost her husband previously, so had never really gone back out into the dating world, but wished to have a companion and wished to have a romantic relationship, but didn't feel like she could in her hormone depleted state. And she felt captive by these adjuvant guidelines. She had undergone mastectomy, chemorads, and then was in her adjuvant monitoring setting, living this life where she was just getting along day by day, and just going home and drinking. She'd become alcoholic because she had this escape into wine, and on and on. It was sad. It was sad. And she really was like, I don't care about, and I was like, well, let's not, be careful. Let's, and so I wanted to go stepwise before she went full bore into dual hormone therapy, but let's try the testosterone first, see if that can alleviate a lot of your symptoms. But I was frankly scared. And so I think about that, and I juxtapose my medical legal fear. What are other practitioners going to think? What are my medical legal risk? And I just juxtapose that against her desire to be normal once again, as she sees it, and wanting to have that life back. And it's tough, right? And that's the human side of medicine, and people need to be able to make the decisions for themselves after a thorough consideration of all the data and the risks that they wish to make, is my viewpoint. It becomes tough when you as a practitioner feel like you're being pulled along with that in terms of medical legal risk. But I've heard OBGYN and other hormone practitioners say they have to sign a clause that, kind of, and I don't know how this would even hold up in court, but, says that, I've considered this, I know the risks. I don't hold responsible the practitioner for anything that could happen, but, I find that the risks outweigh or diminish rather by the benefits. So that's another way to handle it. But what else you got?
All right, so let's do some quick rapid fire ones here as we can. Is it possible to start HRT too early?
I think in general, that's interesting. And so, are we talking from a female perspective, or male, or both?
Well, these are female.
Yeah. So I think from a male perspective, you could, right? Because you shut down your HPA axis. Is it possible? I suspect it's, yeah. I mean, what are you going to? I mean, so that's a tough question, right? Is it possible? Yeah, we're not going to give
enough information in there to really.
Right, we're not going to give a 7-year-old girl or a 16-year-old girl. Why would you do? I mean, But I mean,
And we're not talking about the current trends of medicine towards
exactly
giving prepubescent people who have mush for brains hormones that are going to affect their life forever, and the stupidity of that. I think we're talking more like maybe I read this as maybe like a 25 or a 30-year-old woman, or and so yeah, I think that's individual case by case
basis. I
Yes.
saw a woman recently in clinic that was in her nurse practitioner too. It was in her 30s. I want to say early 30s, but maybe mid 30s. And she had menarche, so she had her first period, and it was kind of normal. But then every single period after that was weirdly light and irregular, and they couldn't figure out what. She had symptoms basically of hormone deficiency. Now there's probably underlying things, and we're investigating that as she sees fit, by the way. But her whole life she had been like that, and one of her biggest symptoms was incredible issues with vaginal dryness and dyspareunia, or painful intercourse. She had been married and then divorced, and had premarital relationships, marriage, divorce, and then was in a current relationship, and never ever with any single relationship ever had intercourse that was not painful. She said it felt like a corn cob and all and all had vaginal dryness, and it was very bizarre. So her estrogen was incredibly exquisitely low. FSH was low too. So there's a whole host of things that we're thinking about investigating in that. But that highlights it's a case by case basis. Yep. And I think in general the answer is yes. But what are you talking about specifically? Are you symptomatic? Do you need them? Well, if you need
and then
them,
I guess you say, like, is it possible to start too early? It depends on your risk tolerance too. Like for a male, you got to be you specifically concerned about fertility and what does too early mean and what are the risks. And so it is possible, but it's case by case basis. What does the term body identical or bioidentical HRT mean?
That's a great one.
Quickly.
It means the hormone that you're given to the patient is exactly what is produced by the chemical structure of
chemical
hormone.
structure. Yeah.
And
where are those generally sourced?
Wild yams, in the case of
I think soy too.
Soy.
Yeah,
phytoestrogens. Yeah. In other words, not from horse urine. In the case Correct. Of progestins, or like somebody that so yeah, vegetables usually. Vegetables and or fruit sources. Yeah.
What if I'm over 60 years old and I haven't started HRT yet? Is it too late?
It's never too late. I mean, clearly, if you were depleted from 50 to 60 and then you start 60, you miss 10 years of benefit. But no, it's not too late. You'll still derive benefit from it, and it's worthwhile.
Yep. Here's an interesting one. I was told by my GYN to put my estradiol cream on my face. Just take a little bit of it, mix it with my face moisturizer. Is this legit advice?
I think.
What would your wife say?
It's interesting. There may be some local effects on the skin that are good. Estrogen is good for your skin. I've seen it in topical hair regimens for hair loss, or making your hair more luxurious, and it does. And so there may be a role for that. Mixing it into the cream, that's kind of bizarre. I would worry about absorption. The bigger question is, why in the world are you rubbing it on your face? If you are using cream as HRT, you're missing the boat. I think it's the worst. It's one of the worst forms of HRT ever. I used to say, "Oh, it's messy. It'll get on people. You have to apply it multiple times. You have to remember it." Here's the kicker. This is the biggest thing. It doesn't change your serum levels. Period. And I've got multiple case studies so empiric evidence in my clinic of doing this with women. I have a female bodybuilder that we eventually had to convert to injections, subcutaneous injections. We doubled her dose. She was on creams. She wanted to stay on creams. Didn't want to get a pellet. Was worried about walking on stage with her butt hanging out, and necessarily, but didn't want a little scar or even the chance of it. So okay, let's do creams. Okay, double the cream, triple the cream. Do it twice a day, 3 times. Nothing. Okay, take it right before you come in. Take it 15 minutes before you come in, and we'll take your serum test. Never could get her above like 30. And
what if you're using the cream for local effect? What if you're using it for?
So that's what I'm saying. Depends what you're using it for. If you're using it for local effect, there may be something to that.
I would think so. It makes sense to me. And the increase in collagen locally, the increase. I did a presentation. It's been a few years, and so I'm light on the information. But it was for podiatrists and hormone cream.
Podiatrist?
Yeah,
For
so it
feet?
was.
So for feet?
Well, it was for podiatrists as well as another. I don't think it was maybe it was dermatologist, and in the role of hormones in skin, basically. And I think it was podiatrist and dermatologist. And so specifically the role of estrogen for collagen production. And there's a significant drop in collagen production postmenopausally due to the direct effect of estrogen. And so
Yeah.
it makes logical sense to me that
Mhm.
maybe, and I don't see any theoretical off the top of my head, a significant downside to doing it.
I don't, unless you're gonna.
Effect.
Yeah, I would be conservative, because one thing about topically applied hormone therapy in general is that, again, one of the reasons it's problematic is it raises your serum levels very fast and drops them very low. So if it was going to do it, there probably is a role for it, like you're saying. There's been studies about vitamins too, topically applied vitamins.
Oh,
In
interesting.
higher levels in the tissues that they're applied to directly, like the face.
But you were just saying you couldn't get serum levels, so you're saying you couldn't get them because they drop so quickly post absorption.
I was saying that, and that's based on other authors and my own personal experience. But if you look at data from a pharmacology lab that is has a probe in somebody and is monitoring continuous serum levels, yes, they rise so fast and they're destroyed so quick. So cardiac output 5 liters a minute, right? So you're going to cycle your whole blood volume in a minute. You're going to go through the liver. You're going to destroy that because it's whoosh. If it all goes in there that quick.
Yeah. I generally tell women with who desire creams in my practice, I don't have a problem medically with it. It's tougher, and I'd say you're going to have to work a lot harder. I prefer pellets. I feel comfortable with them as a physician. I feel comfortable with them for you as a patient. You'll get good results. It'll be easier, but I have no problem doing creams. But just understand you're going to have to do a lot of the work because there's going to be a lot of titration investigation involved in it.
Yeah, and I used to say that. Now I say, just so long as you know you're not going to really change your serum levels much, and if you're okay with that, I
think it has a perception amongst, and specifically because I just had a woman this week who had a couple of these questions, which would kind of furthered my interest in doing this one. But that was her. She viewed it as safer,
right?
And I think physicians view that as well. It's cream, you can stop whenever. It seems to be less, less involved, and
it's not safer. I think if anything, it's the opposite. And we know that. Okay, so there was the gel. There was a testosterone gel, for instance, that either got pulled off the market or had a black box warning. And I forget who was the maker. Maybe it was Abby V.
I think it was
one of the gel. Increased risk of heart attacks. There was, and then just. We know, and we've investigated this interestingly on this podcast series. It's not necessarily the serum level that's dangerous or has the effect, although that can be the case. But what is also the case, and maybe even more so, is the rate of rise. So testosterone. So a lot of testosterone. So if you have a guy that's has a serum level of 1,000 on the left hand, and the guy has serum level on 1,000 on the right hand, but the guy on the left hand, for instance, did intramuscular injection and had a whopping rise real fast, he's going to have a higher level estrogen, other bad side effects, as opposed to maybe the bioidentical guy. Both have the same serum levels at that point in time, right? They've reached a steady state or whatever, but the guy that rose quickly and then stayed there, he's going to have a lot. So the pharmacokinetics and the pharmacodynamics do have huge implications for us on a health level. So it's incredibly important to keep that in mind.
I've switched a few guys since we did that talk on sub-Q injections versus IM injections for testosterone. I switched 3-ish, maybe 4, and I'm still waiting to see. One of them specifically was having to donate blood quite frequently, desired to stay on testosterone. He's like, I'm just tired of phlebotomy. I said, all right, well, here's what we're going to try, and we're going to see what actionable steps or what these actionable steps result in.
So it's changing the way you administer, or maybe he might have to go to pellets even.
Yeah. So. Next question: do I have to be on HRT forever? That's a common one I saw. This one specifically, I am worried about the long-term health effects, but I am 42, had a hysterectomy, so therefore I'm already in menopause.
So we're going to address those two together, right? So
yeah, that was a specific question, but yeah, the first one, do I have to be on HRT forever? How do you answer that when patients ask you that?
I get that question. That's probably one of the most common questions, and or maybe sound like this: can I get off of it if I want to, or that kind of thing? Well, first of all, you can always do what you want to do, right? Whatever. I mean, that's obvious. So no one's going to hold you to that. What you're
I wouldn't
really
say that's obvious. You ever been to a primary care and you try to come off anything they put you on?
I know,
They make you feel like the worst person ever.
I know, that's right. So, so maybe it isn't obvious, and I like to remind, and is why I like to remind. So, good point, and I like to remind people of that. It's always your choice. Okay, so, I tell patients when you say that, and I don't mean this in derogatory or anything, but I'm just letting you know my perspective. When you say that, what I hear is, because I'm biased as somebody who researches this, uses it, and helps people get better with it, and I can't help but be biased by it. I have no choice. But when you say that, I hear, if I ever wanted to be less healthy than I am now, and if I didn't want to receive the benefits of hormone therapy, can I stop taking those? Yeah, if you don't want to have the hormone benefits and be less healthy, which also speaks to the question, I'm worried about the long-term effects, but I'm already menopausal. Okay, well, are you also, and again, there's always this comma. Don't put a period there, put a comma. Always put a comma. Comma, okay, are you worried, comma, about the effects of secondary menopausal symptoms, neurocognitive decline, neuromotor decline, cognitive decline, cardiovascular risk, urogenital deficiency, lower urinary tract, urinary tract infections, osteoporosis, early heart attack. Well, that's cardiovascular. On and on and on. Are you worried about those effects? And okay, that's a little different. And if you are you more worried about supposed effects than those, or which one? So so the first one, can you get off it? Yeah, you can always get off of it. Why would you ever want to? Said another way, more plainly, why would you ever want to? On the other hand, what was the second question? But I'm worried menopause. I'm worried. Oh, is okay.
But
again,
I'm 42 and I'm already
right.
in menopause.
You're suffering, number one, or you're suffering the ill effects that are going to take time to show up, but are beginning now. And if you are worried about the theoretical risks, are you worried about the risk of hormone deficiency? Because you should be, in my biased but expert opinion. You should be.
Yeah, that's a tough one. That's probably the most common question I get from patients, male and female.
What do you think?
I tell them flat out no. I say, if you ever decide to come off this, please just tell me. I will help you do it properly. Don't cold turkey anything. You won't. I say my stupid examples. I say the same kind of script. I'm like, if you win the lottery and you move to, Mexico and you don't want anybody to know it and you just can't have access to a doctor, you just call me up, send me a text, and we'll help you do it slowly.
Right.
But don't come off cold turkey because there's better ways to do it. With men, I tell them, well, if you're at 300 testosterone and you feel all these benefits from being at 800 and you're a 50-year-old man, the benefit of being at 800 won't come any other way than being on exogenous testosterone.
So you're saying similar to what I'm saying, yeah.
Yeah, so you can always choose to come off and you'll go back to that 300 or where you would have naturally declined. Yeah.
Right.
It's probably a better way to do it than cold turkey. But as far as I see it, there is no significant risks that I'm aware of from being on it for a long period of time. Can you come off it? Yes. Will you get the benefit once you come off it? No. And I tell my women too, which is why I tell people in my practice, I would rather sit and talk to you for an hour or maybe have 2 conversations about starting this, because if you're a good candidate and the treatment works as it should, meaning you get great benefit from it and you have all these positives, you are then unlikely to decide to voluntarily come off of this treatment that is providing you so many benefits. And why would you? So let's make sure that you're okay with the time, effort, and money. You're okay with the pros. You're okay with the cons. Let's elucidate all those things before you decide to come on it.
Right.
And maybe just the idea. I see this a lot in medicine with my patients, just the idea of being on a medication. They're like, I just don't know if I want to be on something forever.
That's right, yeah.
And so a lot of these questions, I like to say, well, why? Tell me why that is. They're like, well, this, that, and the other. I'm like, well, it says here you're on blood pressure med. Is that something you were also striving to come off, and maybe we can come, so,
trade one for the other. Yeah.
Yeah, and so sometimes, if they're on 5 medications that are treating the hormone symptoms in a roundabout, maybe you're on a Zoloft and a blood pressure med, and you're on this and you're on that. Maybe the hormone replacement will take the place of those. So, I think, do you have to be on it? That the essence of that question is no, but the nuance of it is we'd go into a discussion about the pros and cons of being on it. There is no aging off hormone replacement, is what I tell my patients.
It doesn't get any better. The natural history of the disease is or the process is it's going to get worse. And I tell people, I guess I would say this. I don't particularly want to have pellets put in my behind. I mean, it's not like, oh gosh, I can't wait for the rest of my life to every 3 months, But what I fear or want to avoid more, or that what outweighs that, is that I don't want to suffer the decline of low T, and I want to garner all the benefits of optimized T as I age, and that it tends to be, so the benefit outweighs whatever negativity I can see in the
right. And it's an individual decision, but I remember
it's absolutely individual,
being at that crux, that crossroads, and it was I was not on any medications at all, and it was sort of this feeling like, God, I have to be on this forever. What am I? I've now succumbed to some sort of whatever.
But don't you think that's? But some of that is, and I've learned this from you, the stoicism or the stoic philosophy of life, and it kind of ties into this or dovetails nicely. It's some of that is kind of coming to grips with aging, and being and becoming different than you were before, and not especially for men who don't have to grow up having periods and worrying about pregnancies and things. I mean, so unless you genetically have some, you've got some bad health problem that was, through no fault of your own, was genetic, and you had to face it at an early age. For the average person, these are diseases of chronicity and of aging, or of epigenetics in our society, or a way we live, but they show up many years later, so you don't have to face it. And then all of a sudden you're having, and I get that, you're like, do I have to go on this I have to be on this forever? Well, I mean, it depends, right? You're going to have to deal with aging and come to some, whether you want to or not, right? You have to. Even not deciding is a decision. So it's kind of, it ties into that. It's tough.
All right,
though.
Last question. It is tough. Last question here, and this one specifically was, I had written this before my patient asked me this week, but she's almost verbatim, and this was relative to females. So, if there are so many health benefits and they are so good, how come all women aren't on HRT?
When you find the answer to that, can you come let me know?
Yeah, I mean, that was such a broad question. And I pointed this female to go to these 2 Instagram pages. I said, there's some specific women and some female doctors who are sort of addressing these kind of questions, as well as a cohort of potentially your peers who are asking these same questions, and you should take some time to read through it and see how they think. And
I would tell her I have that same question, and you can really go down a rabbit hole, right? So if well, what do you
right? Do we want to go down the rabbit hole of conspiracy theories? Do we want to, how much do we want to do?
And also a male, a patriarchal society that, and women's access to, why didn't, if everybody has a God-given right to vote, then why were women, why do we have to have a movement to get women their suffrage rights? And oh my gosh, there's so disinformation, misinformation, lack of information, just like there's inequities in socioeconomic, realms of access to healthcare. It's going to be, that's a whole other podcast, right? Tell them we can do a whole podcast on that. But it has to do with all that. It's so disinformation, misinformation. Well, let's talk about disinformation. The World Health Initiative study, the Million Women study. Okay, so that's one. Lack of information. I wasn't even taught about. I didn't even. Golly, you know what? It's funny. I was never taught that I can recall, and I'd be interested to hear what you say when you did anatomy and physiology and all through your learning. I don't recall being taught. I definitely learned the estrogen progesterone curve and the menstrual cycle. I never knew because I was expressly taught that testosterone was even a female hormone.
No.
So you have
Never.
dogmatic, right? So why was I never taught that? Right. So when you start to get the answer to that question, you start to get answers to this question. So these are deep questions. Then there's, yeah. I mean, like,
Yeah, I saw one of the stats that I can't remember which one of these doctors, these female doctors, which are both OBGYNs, put up and how many hours of training they had. And then their postmenopausal training was 8 hours.
Yeah, right. Yeah.
And it was like it's like from the start of menses through birth, and that was the majority of their gynecological training. And then the postmenopausal woman, I don't know that it's always a malicious thing. It's just, I mean, you could say something like birth was a really historically dangerous activity, so a lot of medicine was thrust towards the making that safer and maybe adding
there was
ways to improve that
system, right?
Yeah,
and women,
and then it never stopped.
Right, and it never stopped. No one bothered to like, oh, we conquered this women's mortality rate, which was high for pregnancy back in the day. High. I mean, it was a dangerous. Not only was it inconvenient and a big deal to get pregnant, I mean, then you had to face childbirth, and you were like, okay, am I going to 50-50? Let's flip the coin. Am I going to survive this? Like, holy cow, man. I mean, it's brutal when you start looking at history like that. But then women and men weren't living to the age where it would even be brought up for generations. Then we kind of conquered infectious disease, not conquered and complete, but, to the point where we could live longer. Now we are, so it's the evolution of medicine has much lagged the need for solutions to these medical problems.
Paradigm shifts are tough in large institutions.
For dogmatic reasons, for historical reasons, for societal reasons. Golly. Yeah, all of that. Gender bias. I mean,
I don't necessarily think that question is isolated to hormone replacement. I say that a lot in my life. Like, if it's so good, why, why aren't all people doing this? It's like exercise. Exercise, if you could bottle it and put it in a pill, you'd be a billionaire. Like, why aren't all people doing this? Right. It's not always a simple, easy answer. But yeah. All right, Doc. Anything else? Any common questions you get? We're not brothers.
No, those were good because we face this all the time in clinics, and I I want to think that we're bringing value to folks. I hope we are. We get some feedback actually that we are, and I mean, just in any podcast could do that. I'm not saying, but having these discussions and parsing these out, I think, are helpful for people because it's not obvious. These are difficult questions, and people get a lot of information thrust at them from all sources now. Bro science, the girls science, whatever that is.
What's the female version of the bro science?
Yeah, it would be like the
be careful.
The wine club, the book club.
Oh no,
the book club science.
You stepped in it.
Oh man!
No matter what you say, you're gonna get hit from some side.
It's gonna be something with books because my wife has all these book clubs that
she really
either offered to join, or as a big thing, or it's a wine o'clock. Like everything's about let's go with the girls and have our wine. Guys do the same thing, have some beers, whatever. But yeah, so I don't know it's something like that somewhere in there. But yeah, I think it's useful to go through these things because, and honestly, it's not. I would love for them to be part of the more popular societal discourse. Because I think there's a lot of people out there needlessly suffering, and a lot of people are even scared to come in and talk to docs about it, even in hormone clinics.
I agree. And I think I specifically started following these female doctors because I feel or felt more comfortable in the male sphere of hormone replacement in terms of understanding what are the typical patient-specific questions and roadblocks that they would be facing, and maybe I had less of a knowledge of that from a female perspective. And so this is an attempt to sort of stay up to date and like try to understand and see what the common questions are, as a male who's taking hormone replacement. And I felt like a lot of the questions that were asked by my patients were questions I had specifically myself. And so it was much easier, I was better poised to answer those, whereas the female side of things I wasn't necessarily, although I do work with all women. I have all daughters.
Ironically, Coincidentally, rather. Yeah.
I had my head GM at the gym. I was lamenting that I was in a team meeting with my gym, and it's all females. It's my wife, my daughter, my GM's a female, my personal trainer's
Wait,
a
now hold
female.
on. But you've got the male. Doesn't the male chiropractor, the guy who did the podcast,
One, but he wasn't at that meeting because
Okay.
because this was the gym specific
Okay.
side, and she's like, "Well, it's not our fault. You're the one doing all the hiring." And I was like, touche. I go, what does that say about me?
Yeah, I know. You're like, wait a second. Yeah. Oh my gosh. Like living with 3 women. No, 4 women. All these years. Does it, has that? Now, yeah, I don't know. It takes a village, man. I like to have both sides of it. It's funny, over the course of my lifetime working with female surgeons, there's some badass chicks, man. And they make, it's funny. They really do see things a little different. And I think the best teams, in my case, surgical teams, but then I've seen it in business and in life in general. And that's why I hate this. Anyway, I don't want to get on that.
You're going to go on the soapbox. So how many is it my perception of the female, and I have no idea, but my perception of the female surgical percentages is pretty low compared to males. Is that true?
No.
Oh, really?
No, it's getting pretty high. I remember when I
well, you're an old surgeon, so was it true when you were in school?
When I was in residency, my class was all guys. My graduating chief class or whatever, 5 guys. But by the time you got down to the second, third years and interns, it was half and half. And I think there was 1 or 2. There might have been 1 or 2 that were. It was like 3 and 2, 3 women,
female
2 guys.
Dominant. Yeah. College is female dominant now. Chiropractic school was about 50-50 when I was there.
Med school, I think.
Here we go. Let's actually get some stats.
Look at
on
that,
it.
50-50. I know med school is like, I think there's more women than men in med school now, but looks like, so look at this. Women are basically catching up, and it's about half and half for women.
Very cool.
Yeah. I've seen good male surgeons, not so good male surgeons. I've seen great, good female surgeons, and I've seen not so great. And I've not found that it's people. Now, I will say in general, women approach things a little differently, but that has value, and men approach things a little bit, and that has value. And so we don't all need to be homogeneous.
There are gender specific differences for sure.
I don't care.
They aren't.
There absolutely is.
There are, but they aren't necessarily categorized as good or bad. They just are.
I will never criticize somebody if they're an adult and they want to pursue a different gender or sex than they were born with. That's your choice as a human being, and you're an adult and a consent. You whatever. That's fine, but there are differences, and there's value in those differences. But I would never begrudge if somebody wanted to do whatever, knock yourself out. That's your choice. You know? But
yeah, it's funny having all girls, man. When I see little boys, I'm just like, what is that animal? I think it's like a beast.
Dude,
I lost all touch, man.
Dude, my boys they're bonkers, dude. They are absolutely, especially my Jet, aptly named. Oh my gosh, dude.
It's funny. One of Stacy's good friends it lives in New York City. Very much a New York City. Just that's her, right? New York City.
I know who you're?
Yes. So her son though had this fascination.
Had children? I didn't even know she had children.
Yeah, she has a little boy.
Okay.
When he was young, had a fascination with John Deere tractors. I don't think he'd ever even seen one. Like he's just like that North Florida blood was in him.
I was gonna say she's from Tallahassee, right?
Yeah, I was like, it was so funny to see this little boy loving John Deere, just loved them. And I'm like, you're in New York City, like grew up in Brooklyn. And just love tractors. It's like, you're a boy, man.
You can't, through and through, man. No, it's not that women can't, but generally speaking, I don't see girls.
It's funny because I don't necessarily think that saying that means that women can't. Like we always have to take that opposite. Like, I'm not saying women can't. Like I didn't say women couldn't. I just said that. I know. But having raised 3
in today's
women,
society, it feels like you have to defend yourself all the time, and I'm like, it's so crazy. I'm like,
myself. I've raised 3 women, and not a single one of them ever loved tractors. And then when I saw this boy, I was like, never had an inkling of a tractor in his life, living in New York City, and was just genetically drawn to tractors. I was like, that's so funny. It's like, get it, boy.
That's funny.
Yeah.
Well, we should do we should look in maybe we should do one for guys.
Yeah, you follow another social guy. I wonder what his. Why don't you look up his questions?
Jeez Louise, there's some. Yeah,
I like him. I like him.
Oh, he's funny, man. He's a funny
good.
dude.
I think he's a Florida resident.
Oh, interesting.
But I think he does good topics, and I think he has good information. I think he's a knowledgeable guy. He's not a polished social media.
No, and he's got a lot of empirical evidence. He's been doing it a long time. I think he does have some good information. I do disagree with him on some things, but for the most part, I agree with him, and I do respect him because he is very. He works at it a lot. He cares about it a lot. He seems to care for his patients a lot.
I agree,
and I do like that. And he seems to be moving the whole thing. I don't, he seems to be having an impact and moving things forward, and that's a good thing. So, and
he deals with the patient base that I necessarily don't deal with, but I think needs information,
and
needs time. Good clinical data, and needs someone that feels they aren't understood. The bodybuilding, the young male, the power lifter, that category.
We're talking about the anabolic doc guy, right? Or whatever his name is.
I think he does great. I think he does good information. I think he's, and I always tell people too, like, you may disagree, and the answer may be A for you, and the answer may be B from you. But if the underlying basis of where we're headed is the best result for the patient,
we're directionally going the same way.
Yeah, at least we have the same. I think the information is directly influenced by the person who's delivering the information. And if I trust you you have my best interest, and I think he honestly does. And I think,
he's very. What I see, I agree, and he seems to always be cautioning his patients, and and so you can't deny that. At least from what I see,
at least the persona that the information that I've digested from him.
The evidence that's out there based on what you can consume on IG, for instance, he does. Judged by that, he cares about his patients.
And he's made me go look up some things, and like,
me too.
I didn't know that. I'm not sure if I really, and I had to go look it up and decide for myself. So,
all right, we'll take a look.
So let's do one on males.
All right, man.
All right,
until next time.
Have a good one.
You too. Bye.